We'll go ahead and start with some introductions. I'm Shannon Bennett. Christy Collins and I are facilitating this meeting with the MCM Network. And with us, we have Dr. Nat, tell me if I say this right, Nasomyont? I did it, okay. Who is a pediatric endocrinologist at Cincinnati Children's Hospital, also an assistant professor in the Department of Pediatrics at the University of Cincinnati. He's joining us to talk about hypoglycemia in our patient population. He is also the lead author of the publication Successful Treatment of Hypoglycemia with Alpelisib in Pediatric Patients with PIK3CA-Related Overgrowth Spectrum. So well-versed on hypoglycemia issues in our patient population. With that, I will go ahead and hand it over to Dr. Nat to chat with us today. Thank you for joining us.
Thank you. Thank you so much for having me today. This is a topic that's very close to my heart. I have privilege of taking care of patients with overgrowth spectrum who had issue with hypoglycemia since I was a trainee. And as you can imagine, that was many years ago. There was little information about this topic in our patient population. Till nowadays, there's still not many available guidance and recommendations on what to do. So I'm happy to share what I learned over the years after taking care of these patients in the past 6 or 7 years. So the title of this topic today I chose is to hope to share the understanding of hypoglycemia in our patient population. And I decided to use a broader term of PIK3CA-related overgrowth spectrum because they can be applicable for patients with segmental overgrowth and of course patient with MCAP as well. I don't have any disclosures related to this presentation. And for today, we will be talking about what is hypoglycemia and why does it happen in a patient with overgrowth spectrum, how we can evaluate hypoglycemia and who should undergo these evaluations, and definitely how to treat and manage hypoglycemia. And we can also talk about future research opportunity as well. To begin with, we'll go over the definition of hypoglycemia. In order to be called hypoglycemia, there are 3 criteria that need to be met. The first criteria is to have a documentation of low blood sugar. And I can tell you that there's no clear cut what blood sugar numbers is considered low. Most endocrinologists will say that any blood sugar below 50 to 60 in children is considered low. There should be also symptoms of low blood sugar as well. And there are 2 groups of symptoms. The first group is adrenergic symptoms, and this happens when the body produces more fight or flight hormone like cortisol, adrenaline. So you see symptoms of increased shakiness, heart racing, increased sweating, irritability, and anxiety. When the blood sugar gets low enough, your brain will start to show symptoms as well. This is called neuroglycopenic symptoms. And these include drowsiness, confusion, blurred vision, weakness and fatigue, and can cause seizure as well. And lastly, these symptoms resolve after treatment or improvement of blood sugar. Again, you need to have documented low blood sugar with symptoms and resolution of symptoms after treatment. I would like to point out that many patients, especially in young children and neonates, sometimes they do not exhibit these symptoms. That's why it's so challenging. And if hypoglycemia happens very frequently, the bodies will start to get used to it. And you can also develop no symptoms despite having low blood sugar as well. This phenomenon is called hypoglycemia unawareness. Whether the patients or children have these symptoms or not, having recurrent hypoglycemia has been shown to result in deficit in neurodevelopmental outcomes. And some of the examples including higher executive functions, cognition, and also vision and motor impairment. So why does hypoglycemia happen in patients and children with PROS? I would like to start with a very simplified diagram of how insulin works. So on here, you will see that the insulin comes from the bloodstream, and it will cross the cell membrane into the muscle, heart, liver, and it binds to a subunit called insulin receptor. And below the insulin receptor, this is inside the cell, there is a pathway that the insulin needs to act on in order for insulin to action. So the most functions of insulin, the most important functions of insulin is to cause increase in glucose uptake into the muscle, for example. So as a result, the blood sugar level will drop because the cells start to uptake this glucose into these cells. This can also promote cell growth, especially if this occurs in the insulin-like growth factor. So that's why the insulin also promotes cell growth as well. So typically, when we have low blood sugar for any reason, including starvation, prolonged fasting, or illness, the body gonna try to decrease insulin secretion to prevent your body from getting too low blood sugar. So when insulin secretion is lower, your blood sugar will start to rise, and your body will also produce a substrate called ketones. And ketone is very important because when blood sugar is low, the brain can use ketone as a backup fuel in order for the brain to continue to function. Now, what happened into patients who have due to PIK3CA mutations, as you can see here, that there is the autonomous activation of the alpha subunit of this receptor part. So despite not having any insulin in the blood, this pathway gets stimulated all the time. So you continue to see the effect of insulin independent of insulin level in the blood. So as a result, you have cell overgrowth. Your body will utilize glucose all the time, leading to low blood sugar. And more importantly, the body will not be able to make ketones as well. So as a result, you'll have constant low blood sugar. And in addition, you don't have enough ketone as a backup fuel to the brain. So you can see there's two hits that can affect the brain. So this phenomenon has a fancy term called hypoinsulinemic hypoketotic hypoglycemia. Means that you have low blood sugar with low insulin level and low ketone production. So the hypoglycemia in patient with PROS has a very variable degrees of presentations and severity. My theory on this is really could be that it depends on how much cells in the body get affected by the conditions. For example, the patient who have just a small vascular lesions or capillary malformations on the arm in a small area, this may not be enough to cause low blood sugar because it's involved only a small part of the body. Compared to this child, for example, if the area of affected area include large area on the arms, on the legs, or this patient that has affected tissue, including the brain and liver, which we know that utilize the most amount of glucoses. So these patients potentially can have more symptoms of hypoglycemia. So some patients may never have hypoglycemia at all. And some patients may have only low blood sugar issues when they are fasting for too long. Or we do have patients who have severe hypoglycemia since birth as well. I also hypothesize that some individuals may outgrow hypoglycemia as they get bigger. This is not due to resolution of the mutation, but because the body gets bigger, they can eat larger amount of food at time, and their liver gets bigger, so they have larger storage, so they can tolerate fasting for a longer time. That's why they may not see hypoglycemia. So who should be screened? So there's no clear guidance on this. So there were some case reports back almost 7 years ago from a group of endocrinologists and pediatricians who take care of these patients. They proposed that every neonate with known PIK3CA mutations should be screened for this. And because neonatal period is a critical time that you can imagine that the body is so small, the resource for backup fluid is also small, so they're going to be at higher risk for having low blood sugar. In my opinion, children at any age, definitely if they show signs and symptoms of hypoglycemia, should be screened for. And in my opinion as well, I feel that this we should include any patient with history of seizure. As I mentioned, that seizure can be the presentation of low blood sugar. And children, small children under age 5 who has to go on prolonged fasting more than 12 hours, and this could be because of illness or if they have to undergo procedures that require fasting overnight, I think they should also be screened as well. And this will require communication with care team before these procedures. So how it should be checked. So it's best checked at time of signs and symptoms of low blood sugar. So that's going to be the time that you can best capture low blood sugar during the time of symptoms. The issue that I see sometimes that the patient have signs and symptoms and their care team asks the patient to get labs through the routine blood work. And at that time, when the child go to the lab, they don't have any signs and symptoms of low blood sugar, and blood sugar look normal. And that could maybe because they have just eaten breakfast before blood work. So having normal blood sugar at that time doesn't mean that you don't have hypoglycemia. So I just want to point out that it's very important that normal random blood sugar does not preclude the presence of hypoglycemia. If we have confirmed hypoglycemia either through the blood work or through a finger stick, I think the next step we should involve endocrinologist. And the reason for that, there are so many causes that can cause hypoglycemia. And some of these are not specific to a patient with PROS. As I mentioned before, that the classic type of low blood sugar in patient with PIK3CA mutation would be low insulin, low ketone with low blood sugar. Now, there are a condition called ketotic hypoglycemia. It happens when you have a smaller body, smaller fluid tank, and you miss a few meals because of illness, and the body is not able to maintain blood sugar in a normal range, but the body can still produce ketones so that the brain can still function. So this is not uncommon at all, even in healthy child. We also know that growth hormone is very important to maintain blood sugar. So if there is a growth hormone deficiency, you definitely can show symptoms with low blood sugar as well. Growth hormone deficiency has been reported in some children with PIK3CA mutations. The last group is almost the opposite of what we described in this patient. So this is due to excess insulin production. And treatment for these 4 conditions can be very different. So I think it's very important to work with endocrinologists, try to tease out what are the causes of hypoglycemia in the patients. And how do we evaluate? So this will require a test called control or diagnostic fast. So basically, we will induce hypoglycemia in a control setting. That means inpatient admission. So we'll ask the patient to be fasting for up to 18 to 72 hours, depending on the age. So for a younger child, most of the time you will ask to fast for at least 15 to 18 hours. And when you fast for long enough, blood sugar start to drop, then we can obtain blood sample to look at some of these hormones, including insulin, ketones, growth hormone, for example, try to figure out what is the cause of hypoglycemia. So once we have confirmed hypoglycemia, we know what's going on. I think it's very important to have frequent monitoring. And the monitoring can be done in many ways. So the easiest option would be having your clinician prescribe glucometer for home use. And this can also be bought over the counter as well. So this will require finger stick to get a blood sample, and you'll get the result within 5 to 10 seconds. So this is considered a gold standard of measurement because you measure glucose in the actual blood. I got asked frequently, what about continuous glucose monitor? So this is a technology that was first developed for patients with diabetes. This device will have a small cannula or plastic tube that is inserted under the skin, and that is used to measure glucose in fluid between cells. So the potential advantage of these technology is that it reads blood sugar for you very frequently. Some model can read up to every 5 minutes, and it provides trends, and also you can share this data to several caregivers. So you can get this data shared to your phone, for example, when you're showering in school or daycare. The limitation of these continuous glucose monitors is many times it can give you false read or false reassurance. So sometimes you will see that the sensor give you normal blood sugar, but the blood sugar actually drops. Or the opposite, that it give you a false alert that blood sugar is low, but when you do a finger stick, it's actually normal. And many times actually not covered by the insurance plan unless you have diagnosis of diabetes. So this can be something you can discuss with your medical team, whether this is something that will be helpful for your child. In terms of management, once we have confirmed hypoglycemia, the first treatment options would be obviously avoid prolonged fasting because that will increase risk for low blood sugar. You can also design meal plan to have a frequent but small meals. Instead of having meals every 8 hours, we may need to feed or provide food every 4 to 6 hours, for example, to have a shorter duration of fasting between meals. And high protein food can always help, and sometimes those are not enough, and your clinician may prescribe starch-enriched meals. So typically we use cornstarch that you have in the kitchen to mix with the food or formula, and that can prolong the duration of, can help the body maintain blood sugar in the normal range for a longer time. Unfortunately, sometimes these oral diet plans are inadequate in many children, especially if your child has issue with feeding, for example. This may require tube feeding. And if we have tube feeding options, so obviously we can try to bolus food more frequently. Some child may need to have continuous feed overnight just to avoid prolonged fasting overnight time. And you can still also incorporate the cornstarch with the feeding tube regimen as well. So for most patients, nutrition management will be enough to avoid or prevent having frequent hypoglycemia on a day-to-day basis. We still see issues, for example, if there's a case of feeding intolerance, feeding tube dislodgement, or acute gastroenteritis, for example, when even feeding tubes, your patient cannot maintain adequate nutrition. Many times these patients going to end up in a hospital requiring IV fluids to provide some support until these illnesses resolved. So that's come to medications options. So as I show you that this is a pathway of the insulin actions, and the patient with PIK3CA mutation have the autonomous functions that trigger hypoglycemia independent of insulin. So there are some medications that act on this pathway that can potentially block the action of insulin. Some of the medication example are the PIK3CA inhibitor that is FDA approved in the United States to treat PIK3CA-Related Overgrowth syndrome. Sirolimus has been used for some overgrowth issues as well. So these two medications block in a different spots, but on the same pathway. So by blocking these signalings, that will lead to a decline in glucose uptake in the cells. So as a result, the blood sugar will not drop as frequently. So I think a patient that may be benefit from these medical management are going to be patients who continues to have recurrent hypoglycemia despite having design of meal plans or feeding plan. There's been a report of using these medications as an adjunctive therapy on top of nutrition management to help with decreasing the frequency and severity of hypoglycemia. So this is one of my patients who was started on initially on feeding treatment regimen with feeding tube, and we were still having low blood sugar fairly frequently, as you can see on the pink lines here. That at baseline, this particular patient have low blood sugar up to 4% of that time using continuous glucose monitor, and also required hospital management for any feeding issues. So we decided to start the medication with the PIK3CA inhibitors. And as we start to introduce the medication, you can see that the time that the patient had hypoglycemia start to also decline. And over time, we are able to actually stop the continuous feed overnight and at the same time maintaining glucose in the desirable range. You can see that this medication did not eliminate hypoglycemia completely, but what was helpful for this particular patient is that this patient can come off the continuous overnight feeds and also continuous feed during the daytime. So it's definitely is something that can help improve quality of life, allow the child to be able to go to school without having to connect to the feeding pump. Another things that I think as a caregivers and medical team need to be proactive and things ahead is to develop a sick day plan, because things happen, especially in school age child age. When your child gets sick with flu, stomach virus, this can increase risk for having low blood sugar. So during this time, we definitely recommend closer monitoring of blood sugar. We might need to check blood sugar more often. We should offer frequent sip of fluid, can be any kind of fluid or drinks that have sugar or carbohydrates. For a patient who is on tube feeds, we may need to provide continuous feed at a slower rate, just to provide support until this illness improve or resolved. If we continue to see hypoglycemia, especially frequent blood sugar below 70, we usually teach the family and caregivers the rule of 15. So this means that giving 15 grams of fast-acting carbohydrates, usually a small juice box will have about 10 to 15 grams of sugar, and reset blood sugar in 15 minutes, and repeat the process until blood sugar is above 70. So this is a short-term solution to treat low blood sugar. And I usually recommend patients to have glucagon. This is called quote-unquote insulin antidote. So it will counteract insulin production and insulin action in the body, and will raise blood sugar very quickly. So this will come in the form of emergency injection kits. So this can be helpful when there is a significant hypoglycemia, and if the patient cannot tolerate any oral or feeding tube feeding. So this can be comes in handy for this situation. After talking to Christy and Shannon, I also learned that our patients get imaging studied very frequently, and it's not uncommon that the patient will need to be fasting overnight, or sometimes even longer than 8 to 12 hours in order to get the sedation for their prolonged imaging studies. So for here, I put that in here that planning is the key here. So we'll need to have a good communication with medical team, the clinician who ordered these imaging studies, the imaging center, and also anesthesia team. So we all should have good communication to have a pre-procedural plan in place. So these are the example of the preoperative or pre-anesthesia plan that I tend to put in the medical chart and communicate with anesthesia team to know. So, for example, in this note, they'll have the defined diagnosis that this particular patient has hypoglycemia condition associated with genetic mutations. Procedure types for this particular patient is MRI brain and spine under general anesthesia. Procedural dates, and then the recommendation before the anesthesia is to have blood sugar check as soon as the patient gets to the imaging center. If the patient wear glucose monitor, that should be removed. So you cannot wear this sensor on certain imaging machine. And we can also consider stock IV fluids that contain dextrose or glucose to provide support during pull-off procedures or imaging studies. And during the time of these sedations, we recommend checking blood sugar frequently, every 2 to 3 hours. Each patient will have different goals for blood sugar. I like to keep blood sugar at least above 70, but definitely not over 180. And after the anesthesia, in the recovery area, so we also recommend decreasing IV fluids, not just stopping abruptly, but maybe cut the rate by half and then check blood sugar, make sure it's still normal, and then stop the IV fluids. Also importantly, make sure that the patient can tolerate some sips or food before sending the patient home. So this plan going to be individualized depending on the severity or type of hypoglycemia that each patient have. So I would like to finish with the summary. So we spent time talking about the definition of hypoglycemia, including what could be signs and symptoms of low blood sugar and screening considerations for a high-risk group. It's very important in order to make a diagnosis that blood sugar need to be checked at time of signs and symptoms of low blood sugar, not at a random time. Once we have hypoglycemia confirmed, I feel strongly that endocrinologists should be involved in order to perform a diagnostic test to identify the cause of hypoglycemia. In terms of management, frequent monitoring may be needed, and the medical management can include use of nutrition, dedicated feeding plan, or consideration of medications if available in your area. And lastly, to be proactive, I think each patient should have develop sick day and pre-procedure plans. And these are based on my experience of taking care of these patients. I myself feel that there's still many unmet needs in this area. So definitely we need to raise awareness among patients, caregivers, and healthcare professionals. So thank you to MCM Network for having me today. I think increased awareness is the first step in order to get a better care for our patient population. There's still a lot of unanswered questions. We still don't know for sure how often or how frequent these patients have hypoglycemia. What are the natural history, why some patients outgrow hypoglycemia, but why some don't. What are some of the predictors? Can we tell ahead that this patient is going to be at risk for having severe hypoglycemia, or if this patient going to be at low risk for hypoglycemia, for example? And we still don't know the best optimal management for hypoglycemia. And I'm hopeful that in the future there will be more interdisciplinary team approach, because this is not one-man show by all means. It's not a job of the patients and family to advocate for this. I think, it's a role for primary care physician, neurologists, endocrinologists for sure to work together and have a better management recommendations for our patients. So with that, I will end my presentation here.
Thank you so much for sharing that with us. Opening the question and answer time now. If anyone has any questions, feel free to pop those in.
I'd like to start, and maybe I can give people an opportunity to type in their questions.
Sure.
Dr. Nat, a lot of times our patients understand that there's a risk of hypoglycemia in the condition, but they're not, they don't have an endocrinologist. So if they have a finger stick monitor, what kind of levels would raise alarm, and what actions should they take at different levels? Like what levels are dangerous? What levels are low but not dangerous? Could you talk about that a little bit while we let the Q&A come in?
Yeah, definitely. That's a very important questions, and also challenges that we have as well. So as I mentioned before, that there is no clear cut for what number even is considered hypoglycemia. If you ask 5 endocrinologists, you may get 4 different answers. So I would say definitely the number that is low enough to cause symptoms. So in general, any number below 70, that when you should pay closer attention, because most children will have blood sugar above 70 at all time. Okay, so I think below 70, that should start to raise suspicion for any blood sugar problems. Definitely anything less than 50, I would be concerned. Okay. I think between 60 and 70 is going to depend on the contents. For example, if your child's not been eating for a good 18 hours for any reason, having blood sugar in mid-60s may be expected. But definitely if 60 is low enough to cause symptoms, that I think should probably work out. So I think just to make it easy, I think less than 70, we should start to be concerned and kind of go from there.
And when you say start to be concerned, does that mean make an appointment with the endocrinologist? Okay.
Yeah.
Thank you.
Yeah. And we can start with primary care doctor first, and, have that information to show then that this is my child blood sugar. And what I find helpful is have a little diary. Sometimes it's hard to go back and think what happened two weeks ago with that low blood sugar. So have some kind of note to say that, okay, my child blood sugar was 60 at this time. At that time, it was fasting morning, and my child has symptoms ABC. That's going to be very, very helpful for the clinician.
Thank you. We have a couple of questions that have come in. Lindsay wondering, how long does it take for VIJOICE to have an effect on low blood sugars?
I see. Yeah, so I would say from my experience, I would say it's probably take week, if not maybe weeks, to start to see the effect. I think it's also depending on the starting dose. If you're starting at a higher dose, I think you may start to see the effect quicker. And each patient, from my experience, have a quite different response as well. There are patients who you start to see better blood sugar within the first week as well. Some patients may need a little bit longer time. I would not expect it to see within days.
Okay. Next question is from Jessica. She says, hello, do you see adults? We have a local medical team. However, our local team is unsure how to manage or create a care plan for our MCM patient. Do you offer consultations to help with creating a plan that our local medical providers can reference?
Thank you. So this is area that we also need to have a better access to transition care as well. So unfortunately, I see patients only under age 20. So I think this is the challenges that we have with many children and young adults with chronic medical conditions, that pediatricians are more familiar with these conditions, but in adult world, not many know about these conditions. I think the concept that I share with you, even though I focus, on children, can still be applicable for adults. So, feeding management or frequent monitoring, for example, and adults should still have a sick day plan. So I think this still can be applicable.
Okay, thank you. Last question that we have so far is from Sarah. Are there any other options for overnight hypoglycemia apart from cornstarch or glycosade? We find these aren't as effective as previously in early days.
I see. Yeah. So there are some protein powders that you can consult with nutrition that can get it through the prescriptions, even though it's not technically carbohydrates per se, but adding more proteins can be helpful as well. So I think that can be an option.
Okay. Sarah also asking seizure activity, can it cause more hypoglycemic attacks? We're finding if we have seizures, then we're having low blood sugars all night.
Yes, definitely. It can. This one is hard because we don't know which one is egg or chickens. So it could be bidirectional. That if you have low blood sugar to begin with, that can lower the threshold of having seizure. And if you have seizures, you can imagine that the muscle and gonna uptake glucose more because of seizure activities. So definitely seizure can lower your blood sugar as well. So it's bidirectional.
Okay, thank you. It looks like that was the last question that we have for right now.
I have another question. Could you talk a little bit about what kind of advocacy you've done in order to get continuous glucose monitors for patients? Like what was required to get them for non-diabetic patients?
Right. So I think this will require work from your from medical team. So what I found successful is first to document the risk of having hypoglycemia. I clearly document in medical chart that these patients are at risk for having seizures, having low blood sugar can affect neurodevelopmental outcomes, and we have had documented low blood sugar for these patients. So I think that's going to be the first important points to make. The second most important point is, especially if the patient is at risk for having hypoglycemia unawareness. For example, small children, children who have delayed speech, that they cannot verbally communicate when they have signs symptoms of hypoglycemia. And so those I found that having those one of those two documentations in the medical chart, most of the time we can overcome the denial that we received in the first place. Many times require us to write a letter to appeal the insurance, and sometimes it recurring once a year, we need to revisit this again with the insurance change each year.
It looks like Sarah has another question. High carb type foods, we're also seeing low blood sugars. We're trying to switch to a low glycemic type diet at the moment. Seems to be a bit more effective. We are having higher blood sugars to 12, then within an hour or less dropping to 2.6 to 2.9. Could this be hyperinsulinism?
I see. So I don't think we can tell for sure based on the pattern. The point that I would like to make is that there's a dysregulation of insulin signaling. So many times the blood sugar doesn't act in a way that you would expect with this condition, which is very similar to hyperinsulinism. The hyperinsulinism is your body makes insulin secretions all the time. So insulin level is high all the time. With the hypoinsulinemic hypoketotic hypoglycemia that is more common in patients with PIK3CA mutation, your insulin level is actually low, but you still have the same activity of insulin there. So I think the blood sugar pattern is not always telling us which one is the cause. But I agree that many times when there are a big surge in sugar intake, I think of this more of simple sugar, anything that kind of sweet that the body will break down into simple sugar fairly quickly. You're going to see a big spike of blood sugar, and that can kind of trigger either insulin action or insulin secretion. So you can almost see the pattern of roller coaster in your blood sugar. So sometimes it kind of exaggerated. If you start with blood sugar at 100, it spikes to 180. instead of drop back to 100, it actually keep dropping to 60, 70. So that's a very important point. I think in general, even though we find that carbohydrate helps in general, but I would advocate for we call complex carbohydrate, especially if you can balance that with good amount of proteins and fat. That's going to be best. So definitely I would avoid using just anything that just too sweet. I think that can be helpful for treatment at the moment if your blood sugar dropping too much. If you want to bring it up quickly, that can be helpful, but not a long-term solution.
I just want to interject that we have heard this from other patients also, and one of them has had it described as reactive hypoglycemia.
Yes.
Okay. So whatever that patient is experiencing, I have heard this same story from other patients as well. I just wanted to add that.
Susan says, if we have a child who is on Alpelisib and has to hold it because of illness, how often would you recommend checking blood glucose?
So I think if you're already have a history of low blood sugar to begin with, and you're taking a Alpelisib, that can mask low blood sugar because it's kind of like a treatment in a way. So I would recommend at minimum maybe at least 6 hours into fasting. I think you should start checking, and it can be as frequently as every 4 to 6 hours. I think it depends on what the intake looks like. If you can ensure that your child can continue to sip some kind of fluids that have carbohydrates in there, or milk, for example, I think checking may not be as important. But definitely, if your child cannot tolerate any oral intake that day, I think it may be the indications to come to the emergency room.
Okay. Jessica says, I might have missed this information in your presentation. Do you see gastroparesis in patients with severe hypoglycemia? As Sarah has aged, she has developed both as an adult. She is 28 years old now, and her problems have progressed.
I see. So personally, I have not seen that. It could be that most of my patients still young. The blood sugar can affect motility of the bowel and stomach for sure. We tend to see that more with higher blood sugar issues. This is a complication that can happen with patients with diabetes. So I personally don't have any experience in my patient yet.
Okay, thank you. It looks like that was the last question that we have for now, unless Christy, you have any.
We have another mention. So Sarah's asking a lot of questions, and I want to mention that Sarah's in England and does not have access to Alpelisib. So you can answer her question, but I also wanted you to maybe address the use of other medicines for people who don't have access to Alpelisib, because she's not the only person in this situation. I hope you don't mind me saying that, Sarah, but go ahead and do her question first.
Sure. Yeah. She's just asking if you could explain a little more on reactive hypoglycemia. What is it? What to look for?
Yes. So for the reactive hypoglycemia, so this is, kind of describing the same. This is a reaction. So it's usually triggered by having a glucose surge. So when the glucose rises very quickly, most of the time after like a large load of, for example, sodas or juice, that have a high sugar content. So your body will see a big surge of blood sugar in a short period of time. And many times when the body see that rise, it will kind of exaggerate in terms of the insulin production. So your body can produce large amount of insulin all at once in order to bring that blood sugar down. But because of these, most of the time these occur with the fast-acting carbs. So by the time your insulin start to work, many times blood sugar is already coming down because your body already digests those, sugar. So as a result, we kind of see a mismatch that, blood sugar is already coming down, but the insulin still keep rising. So that can be seen in any patients actually. we tend to see more in patients on tube feedings for some reason. This is not unique for our patient population, but can be seen. So in order to avoid that, I personally believe that balanced diets is always the key here. Every time we have carbohydrates in, we should also make sure we have proteins and fat and fibers in it. So this will be a best way to prevent reactive hypoglycemia. And then, so to Christy questions about other medications. So as I showed on the diagram before, there are many, some other areas that we can address here within the pathway. So some of the medications that I think probably more common and more commonly used in some countries going to be the sirolimus or mTOR inhibitor. So there has been patients who get these prescription medications to help with hypoglycemia as well. My experience is limited to one patient, and my patient actually did not see much improvement with sirolimus. So we actually went with sirolimus route first before trying Alpelisib. There are also some other medications that are being developed on a different area on this receptor on the insulin receptors as well. So I don't have a better answer here, but I understand the limitations in a certain region of the world.
Thank you. Susan asks, if a patient seems to be growing out of hypoglycemia, is there a risk of them regressing?
I see. Again, this is something that is my hypothesis, so I don't have any proof yet. I think there's still always a risk in a setting of illness. For example, if you have acute illness or you have to be prolonged, you have to fast for a long time, even though you quote unquote outgrow hypoglycemia, I personally feel that it still can be helpful to check blood sugar during those times.
Okay, it looks like that was the last question that we had in the Q&A.
I have one more question. I often tell patients that their doctors can contact you. Is that true?
Yes, at any time. Yes.
Okay, so let's say for the adult patient, if they are being cared for by an endocrinologist who has questions about this condition, could their doctor consult with you as a professional, not as a, yeah?
Yes, definitely. I'm happy to share, what have worked for our patient population. And I think, family can work with an adult endocrinologist and see what can be utilized in their care plan. I'm happy to share general concept. And even as an endocrinologist, I can tell you that before I get involved in taking care of this patient, this pathway is not something we memorize or have a good understanding, even though we see patients with blood sugar issue all day, every day. This is a very detailed, kind of niche area, I would say, that unless you take care of these patients, it's very hard to grasp the concept.
That's very helpful, because I think a lot of us experience that when we take this to the doctors, that we feel like they don't know what to do with us. Yeah. So that's helpful even to understand that it's niche. And so thank you.
So again, we just want to appreciate joining this webinar today. Thank you for your time, Dr. Nat, and sharing your knowledge and expertise with us. We really appreciate it.
Thank you so much for having me.